Thymectomy in myasthenia gravis. The thymus in myasthenia gravis. Thymus is abnormal in most patients with myasthenia gravis. About 70% show thymic lymphoid follicular hyperplasia. More than 10% have thymoma. Hyperplastic thymus contains T lymphocyte, B lymphocyte, plasma cells, myoid cell expressing acetylcholine receptors. Myasthenia gravis clinical subtypes. Myasthenia gravis subtype, age of onset, thymic histology, autoantibody, comments. Ocular myasthenia gravis, age of onset, adult in United States and Europe, childhood in Asia. Thymic histology is unknown. Autoantibodies are AChR 50%. Early onset myasthenia gravis, less than 50 year, thymic histology hyperplasia, AChR antibody, male is to female 1 is to 3. Late onset more than 50 years, normal thymic histology, AChR antibody, titin antibody, ryanodine antibody. Males more than females, anti-titin, ryanodine antibody associated with severe disease. Thymoma, more than 40 year usually. Thymic histology is neoplasia, AChR antibody, titin antibody, ryanodine antibody. May be associated with other paraneoplastic disorders. Musk myasthenia gravis, less than 40 years, normal thymic histology, Musk antibodies, marked female predominance, selective oropharyngeal, facial, respiratory weakness in some, IgG4 antibodies. LRP4, 30 to 50 years, unknown thymic histology, LRP4 autoantibodies, response to therapy similar to AChR myasthenia gravis, IgG1 antibodies. Seronegative generalized myasthenia, variable age of onset, hyperplasia in thymus, autoantibodies, antibodies against clustered AChR, agrin, or cortactin in some cases, presumed unidentified antibodies in those without low affinity AChR antibodies, agrin antibodies. Intrathymic pathogenesis in myasthenia gravis. Thymus provides an environment for autoimmune response against AChR. Thymocytes can spontaneously produce anti-AChR antibodies. Supports concept of intrathymic pathogenesis of myasthenia gravis. Thymic AChR subunits may trigger autosensitization. Musk expression in thymic myoid cells suggest thymic role in Musk myasthenia gravis. Thymoma and autoimmunity. Thymoma cells express self-antigens including AChR-like epitopes, titin-like epitopes, ryanodine receptor-like epitopes. Myasthenia gravis associated with thymoma contain autoreactive T cells. Defective immune regulation may occur due to reduced AIRE gene expression, loss of regulatory T cells. Thymomatous myasthenia gravis, seen in approximately 10 to 15% of myasthenia gravis patients, occurs equally in males and females. Peak age of onset is around 50 years. Patients commonly have striated muscle antibodies, that is, titin antibodies, ryanodine receptor antibodies. Benefit of thymectomy. International randomized controlled trial showed lower quantitative myasthenia gravis scores, reduced prednisone requirement. Benefits persist up to 5 years after the surgery. Improvement after thymectomy is gradual. Clinical response may continue for months to years. Ideal candidates for thymectomy. Best outcomes are seen in young patients, females, and earlier disease. Improvement may still occur even after long disease duration. Recommended in early onset generalized AChR positive myasthenia gravis, selected patients between 50 to 60 years, patients with thymoma, and patients intolerant or refractory to the immunotherapy. Thymectomy in ocular and Musk myasthenia gravis. Generally not recommended for purely ocular myasthenia gravis. May be considered if medical therapy is inadequate. Role in Musk myasthenia gravis remains uncertain. Most evidence suggests limited benefit in Musk myasthenia gravis. Some Musk myasthenia gravis patients achieve stable remission, drug-free remission Post-thymectomy. Surgical approaches for thymectomy. Traditional approach. Transsternal sternal splitting thymectomy. Minimally invasive technique. Transcervical thymectomy. Video-assisted thoracoscopic thymectomy. Robot-associated weights. Minimally invasive methods offer less postoperative morbidity, shorter recovery, better cosmetic outcomes. Transsternal approach preferred in thymoma for complete tumor removal. Repeat thymectomy. It is considered when relapse occurs after a good clinical initial response. Incomplete thymic removal is suspected. MRI and cardiac gating may identify residual thymic tissue after the thymectomy. Management of thymoma. Surgical resection recommended for nearly all thymomas. Residual normal thymic tissue should be removed. Elderly or high-risk patients with smaller tumors may undergo periodic imaging follow-up. Radiation therapy is recommended for stage 2 tumors, WHO type B2 and B3 thymomas, stage 3 and 4 tumors. Advanced tumor requires multidisciplinary management. This is the WHO classification of thymoma. Type A, spindle or oval epithelioid cells, very few lymphocyte, usually a benign behavior and excellent prognosis is present. Type AB, mixture of type A areas with lymphocyte-rich areas, carries good prognosis. Type B1 resembles normal functional thymus, abundant lymphocyte, frequently associated with myasthenia gravis. Type B2, increased epithelial cell with many lymphocyte, more aggressive than B1. Type B3, predominantly epithelial cell with mild atypia and few lymphocyte, higher invasive potential. Type C, thymic carcinoma, frank malignant cytology with marked atypia, highly aggressive with a poorer prognosis. Masoka-Koga staging system for thymoma. Stage 1, complete encapsulated tumor with no microscopic capsular invasion. Stage 2A, microscopic invasion into the capsule. Stage 2B, macroscopic invasion into surrounding mediastinal fat or mediastinal pleura. Stage 3, macroscopic invasion into neighboring organs such as pericardium, great vessels or lung. Stage 4A, pleural or pericardial dissemination, drop metastasis. Stage 4B, lymphogenous or hematogenous metastasis to the distant organ or lymph nodes. Key take-home messages. Thymus plays a central role in myasthenia gravis pathogenesis. Thymic hyperplasia and thymoma are common in myasthenia gravis. Thymectomy improves long-term outcomes in generalized SHR positive myasthenia gravis. Benefits include reduced disease severity and steroid requirement. Surgical approach should be individualized. Complete thymoma resection is essential for optimal management.